Welcome to Fluorescene.
Hi, everybody. So I am here today with three distinguished practitioners and colleagues, Dr. Elizabeth Yeu, Dr. Andrew Morgenstern, and Dr. Barry Eiden. And we're here to talk about their exciting and cutting-edge meeting, the International Keratoconus Symposium, also known as IKA. And IKA is going to be held live and online April 22nd and 23rd. The live session will be in Scottsdale, Arizona. And now to talk more about our speakers, Dr. Elizabeth Yeu earned both her undergraduate and medical degrees at the University of Florida College of Medicine. She went on to complete residency training in ophthalmology at Rush University Medical Center in Chicago, Illinois, where she had the distinction of serving as chief resident. She served as an assistant professor at Baylor College of Medicine in Houston, Texas, where she completed a fellowship in cornea, anterior segment, and refractive surgery. Dr. Yeu joined Virginia Eye Consultants in 2013 and serves as assistant professor at the Eastern Virginia Medical School in Norfolk, Virginia, and as medical director of the CVP Mid-Atlantic Surgery Center. In addition, she serves on the board of directors for the Virginia Eye Foundation, as an examiner for the American Board of Ophthalmology, get this, as president-elect of the American Society of Cataract and Refractive Surgery, as chair of the cataract section of the Ophthalmic News and Education, the One Network, for the American Academy of Ophthalmology, and as chair of the AAO Annual Meeting Refractive Surgery Subcommittee. Dr. Yeu's published many articles. She's a sought-after lecturer on topics including refractive cataract surgery, lid margin and dry eye disease management, and complex lens-based surgical procedures. Dr. Morgenstern is a graduate of Boston University and Nova Southeastern University College of Optometry with clinical honors, and completed his training at the Bascom Palmer Eye Institute at the University of Miami School of Medicine Department of Ophthalmology. Dr. Morgenstern is a clinician at the Walter Reed National Military Medical Center in Bethesda, Maryland, with additional contract duties researching acute eye injury, blast eye injury, and vision dysfunction associated with traumatic brain injuries. Dr. Morgenstern is also director of the American Optometric Association Clinical Resources Group that develops the AOA evidence-based clinical practice guidelines. Dr. Morgenstern is the co-founder and president of the International Keratoconus Academy of Eye Care Professionals, IKA, past president of Optometric Cornea Cataract and Refractive Society. He's also a fellow of the American Academy of Optometry and a distinguished practitioner and fellow of the National Academies of Practice. There you go. Recipient of the 2019 Orion Award from the Armed Forces Optometric Society, as well as the 2015 Distinguished Alumni Award from NOVA. I need some oxygen.
We're good. We're good, Alan.
No, we'll leave out Barry, right? Barry Eiden, Dr. Barry Eiden is president and medical director of North Suburban Vision Consultants, a multi-specialty group practice. He's president and founder of the International Keratoconus Academy of Eye Care Professionals. Dr. Eiden is also co-founder and president of iViz Eye and Vision Research Institute. Dr. Eiden is an assistant clinical professor at the University of Illinois at Chicago Medical Center and an adjunct faculty member of the Indiana, Illinois, Midwestern, Salus, SUNY, and UMSL Colleges of Optometry. Dr. Eiden is past chair of the AOA's Contact Lens and Cornea section, fellow of the American Academy of Optometry, and a fellow of the Scleral Lens Society. And I'm about out of words right now. That's it. That's all. You guys are going to have to carry me through the rest of this. Andy, I'm going to start with you.
Yeah, sure.
Tell our viewers about what is the IK and why put on this meeting?
Yeah, sure. So, Alan, I just, on behalf of our organization and my fellow co-chairs here, I just want to say thanks for having us on. It's a great opportunity to get the word out. And really, to answer your question, IKA stands for the International Keratoconus Academy of Eye Care Professionals. Why are we putting on this meeting? Well, about 10 years ago, essentially what happened was a lot of technology was coming out about keratoconus, or measuring keratoconus, especially, and Liz could probably talk about this in the refractive surgery world. We had a lot of patients that had refractive surgery, ended up getting post-LASIK ectasia, and we didn't know why. And that's because the technology way back when was really only looking at the front surface of the cornea. Since then, technology has evolved. As technology evolved, it evolved faster than the education was happening in residency programs and schools, both in the optometry and ophthalmology world, and we had to get the word out. So we founded this not-for-profit educational society called IKA. It really works with optometrists and ophthalmologists. It's really important for us to understand this is a combined profession organization, and we really wanted to just get the education level up. And so one of our goals when we started this organization, like a decade ago, was to have an in-person live meeting where we can really get on the road and bring this education to our fellow eye care providers. I just want to also say it's so important for us to get this out. We're making it free to register for students, residents, fellows, active duty service members, and veterans to attend, because we feel that population needs this information and needs to put it in practice.
And not to mention that with this improved technology, the known prevalence of keratoconus went up. I mean, obviously it was the same as it always was, but what we were able to find out about it was that it's much more prevalent than we previously thought.
Look, the three of us were not out of school 5 minutes ago. And when we had to learn this stuff, the prevalence in the literature, and that literature was from 1986, prior to the use of corneal topographers, was established as 1 in 2,000. And any of us that work in a refractive surgery center know that the prevalence of keratoconus is not 1 in 2,000, because we see these patients daily coming into our offices. And so what we had to do was the whole community had to do was really do the research, get the message out, find the hard numbers. And we know now today that the prevalence of the disease is way less than 1 in 2,000, basically because we have this new great technology.
And the days of counting on the scissors reflex of a retinoscope are long gone. So Liz, can you tell us what's unique about the IKA faculty?
Absolutely. Well, there's so many parts of the IKA faculty that make it unique, but this conference itself is so unique because there's such an emphasis on it being a very combined, bi-directional, shared information between OD and MD, nuanced and expertise, because truly there is the medical side, there's a surgical side, there's a refractive side, but there's, just as to your point, the understanding that the incidence of keratoconus is not only 1 in 2,000, it's probably not as common as 1 in 20, as some Middle Eastern literature shows, but it is very common. And it's what I tell patients, somewhere between 1 in 250 to 1 in 400. But it's so important for us to be able to, one, put patients first, but two, I have to identify it. I'm being asked to rule it out in younger patients. I'm trying to rule it out effectively in my refractive surgery evaluation patients. I'm trying to screen for it. And let me tell you, I also want to be able to place patients first, and therapeutically work with my OD colleagues to help my patients so that they don't need surgical intervention to the point where we can prevent allograft transplantation or delay it as much as possible. And luckily, we have bridge therapies to get us there. And what better way to do that with experts in the field? I love the fact that we have Belin as well as Ambrosio. I mean, we are using their index from the Pentacam, and they're both going to be speaking. Bill Trattler has been in every single study known to collagen cross-linking. And in fact, he has treated pediatric patients, and in fact, very personal experiences, very publicly known that he's even treated his daughter. And then obviously great faculty from both the academic centers, Dr. Uri Soiberman from Wilmer Eye, as Dr. Loretta Flynn from Case Western, as well as Mary Prudden, who's the executive director of the National Keratoconus Foundation, as well as many others. Even my own puppies are super excited to be able to attend, and they're absolutely saying, you better come. So this is a very exciting meeting that I do think has many, many reasons to be unique. And I am so fortunate to be able to be alongside Dr. Morgenstern as well as Dr. Eiden, and being able to and they're just so passionate that being alongside them has made me even more excited to be able to share and to learn about, what else is in the pipeline and how else can we be more exact at identifying from a biomechanical standpoint, genetics, everything else, as well as a therapeutics.
That's great. Thank you. Barry, can you chime in on your thoughts on the faculty and the content you'll be bringing to our viewers?
Sure. I mean, we're so excited to have, I call it the who's who of keratoconus, speaking at this first inaugural IKA symposium on keratoconus. It's very, very unique in a number of ways. First of all, I think, to my knowledge, it is the first exclusive meeting on keratoconus, only keratoconus and everything keratoconus. In addition, as Liz was mentioning and Andy was mentioning, the fact that it is a cooperative effort between all the eye care professionals, and we're all going in this with that same goal of disseminating the most current information about what's available today and what we can look forward to tomorrow. This is really critical. The basis of everything we do is realizing that keratoconus, number one, is far more common than we ever thought before. That's number one. Number two is the fact we can do something about it. It's great to know that it's much more common, but if we had no way of managing it and controlling its progression, which we obviously do now with technologies such as cross-linking, so it really changes the entire way we approach this disease. We've got to get this message out clearly. We also have to realize, as Andy mentioned, that we know that in the pediatric population, keratoconus is also far more common. And we're going to actually have a session exclusively dedicated to pediatric keratoconus. Liz is on the panel, I'm on the panel. And we're going to really dive deep into this topic because we believe it's going to impact clinical practice in a very significant way moving forward.
That's great. Thank you for that. Now back to Andy for a second. Tell us about any unique sessions that you're going to be having there.
Yeah, thanks, Alan. Good question. When we really sat down and kind of mapped out what we wanted to do with this meeting, we wanted to take everybody really from from the patient walks in the front door, thinking practically how we're going to get through the exam, ultimately to where hopefully we don't have to have a surgical case, but ultimately where Dr. Yeu sits in that surgeon's chair, if our patient has to go all the way to that endpoint and everything in between. We wanted to make it different. All of us have been to conferences before and lectures. You go in, you sit down, you listen, you get the information, you leave. IKA wants to make a difference on Monday morning when you return to the clinic, and when the information that you gather, that you can actually functionally change the way you practice. So a couple of things. Number one, we want to, since we're going to have all the experts in the room at the same time, well, why not take advantage of that and develop something really good? So we're developing a keratoconus algorithm of care, essentially a flow chart from the experts on how to take that patient from when they walk in the front door, from detection and diagnosis, all the way through to where their personalized treatment ends with this disease. It could be cross-linking. It could be with a scleral contact lens. It could be with a soft contact lens. It could be with a partial thickness or a full thickness corneal transplant. But however that is, we want to map it out for doctors that necessarily don't have the all the expertise like many of the speakers in the room, because this is going to guide them through it. Not only going to develop that algorithm, but we're also going to develop a white paper. We want to include everybody that's part of it in the room as authors and publish this and give it out for free when it's all done. The second thing that's really unique that we're doing, I think it's a first of its kind also at our meeting, is that at the end of the day, we're learning so we can help our patients. Now, Liz, Barry, and I, and a lot of our colleagues, we've been on social media in patient-facing groups. And there are groups out there that are 20, 30, 40,000 people, patients strong, of people suffering with the disease of keratoconus. And let me be honest with you, they know a lot. They're doing their homework. They do their research. And why not interface doctors and patients in a live forum? So our last session of the second day is going to be just that, where we're actually giving patients a portal to dial into, like a Zoom style meeting. We're going to have a panel of doctors, optometrists, ophthalmologists, people from our industry, and we're going to let the patients pre-ask questions. We're going to ask those questions to the doctors and let the patients and the doctors interact live in one of our medical meetings. Again, I think it's a first of its kind thing. I think it's going to be very beneficial. We've already had a ton of people register for it, so I think it's going to be really exciting.
As somebody who spends a lot of time online in eye care places, I did notice that about keratoconus. It's the one condition where I see a lot of engagement between doctors and patients online, where you don't see it in a lot of other eye care condition. So that's a real, I think unknowingly, you really tapped into something huge there that is going to really, I think it'll blossom, and a lot of unexpected positive things will happen both from the doctor side and the patient side from that. So kudos to you guys for coming up with that. I'm going to move back over to Liz for a second. From a surgeon's perspective, tell us about why it's important to identify and diagnose keratoconus as early as possible, and what we'll learn about that at the symposium.
Sure. That's a great question. I think there's like two ways that we can think about this. The reason that we want to be able to diagnose it as early as possible is, one, obviously, if we are screening younger patients, we now have options to help prevent progression. And it gives us options to help therapeutically. So even before we place them in contacts, we can consider cross-linking off-label for the pediatric population. I know doctors, I myself have not, but for pediatric patients, we can, for those who, while it takes a little bit more time, cross-link patients at a younger age, even single digits, so that even if they need to be recross-linked in the future, I mean, we know allograft transplantation, the younger we transplant them, the greater their chance of rejection, and repeat transplantation is not the answer. So we want to be able to help them as much as possible, and in conjunction with the proper education, prevent eye rubbing, prevent that iatrogenic trauma. All of that makes sense, but that requires putting the patient first. It is bidirectional. It is working with specialists, and that is ODs and MDs. So that's one. But then two, it's obviously for the refractive surgeon, and recognizing now is the perfect time because refractive surgery options are expanding. And truly, my conversation is refractive surgery is for everyone. It may not be on the cornea for you, but we can offer an option for you. And if it's not LASIK or PRK or SMILE, it may be that we are placing something like a contact lens in your eye that is a next generation level that can fix your vision, but it's safer for you, less chance of you running into problems down the line. So because we have this breadth of technologies, having that knowledge for the surgeon, it is only going to empower us to make the best decisions for our patients. And so it's kind of that two-prong approach as to why having the medical basis is going to make us the better surgeon.
Fantastic. Fantastic. Outcomes also are better when you diagnose it, especially in children younger, I believe. But I'm out of my league talking about keratoconus on that level. I'll learn that when I come to the conference. The next question is for Barry and Andy in that order. Barry, where do you see the biggest impact for early keratoconus detection? Pediatric optometry, pediatric ophthalmology, and in that area. Tell us more about that.
So the answer is yes. So in both. Any of us that deal with pediatric patients, whether you have a pediatric specialty practice or a general eye care practice, have to keep in mind the importance of screening for keratoconus. You know, Andy and I have given talks together for years, and we always use the analogy of glaucoma. So you have a patient, for example, who's 12 years old in your chair. You'll measure their eye pressure. Then we'll always poll the audience, how many people have diagnosed primary glaucoma in that age group population? I'm not talking about congenital glaucoma or traumatic glaucoma, but primary open angle glaucoma, and no hands go up. But yet they're measuring the pressures on every one of these patients. And we're not suggesting they shouldn't. However, if you ask them, are they screening for keratoconus in any way? The answer is absolutely not. So again, this is a much more common condition in that age group. It has tremendous effect on a patient's quality of life in a negative way if it's not treated. And we have treatment, as Liz was mentioning to you, to halt progression. And there are going to be newer and newer technologies that make this as effective or more effective and safer as time goes on. So this is really, really important. So I think pediatricians need to be considerate of this fact. All eye care professionals, especially those who have pediatrically oriented practices, need to start considering this as a mainstay of their diagnostic work that they'll do with these patients.
Great. Andy?
Yeah. So just to follow up on Barry's saying, we think as a group, well, let me take a step back. Keratoconus does not just materialize one day when you're 25 years old, right? You're not born perfectly healthy eyes and then whammo, one day you have corneal hydrops, right? So the way the disease progresses is that it starts on the back surface, generally speaking, on the back surface of the cornea, and it progressively gets a little bit thinner. It progressively advances, the elevation on the backside, and ultimately it changes the shape of the front surface of the cornea, which is generally speaking where we saw it with a corneal topographer. We learned in our schooling that keratoconus really manifests itself somewhere in the 20s and 30s, the second to third decade of life. But the reality is that all of these patients progressively start to change at some point. Our goal from IKA is to spread the word that all of these patients need to be, especially genetic biological family members of keratoconus patients, and also, eye rubbers, and then specific population like the Down syndrome population, which we have a speaker, Dottie Fidel, talking about that. We want people to understand that getting these patients looked at in a young age, where we can identify them early, we can save vision. We can, with cross-linking now, we can stop them from needing a corneal transplant later in life. We can stop them from needing advanced medical huge scleral contact lenses if we can get them cross-linked and keep them in a soft lens. That's a very viable option for these patients. It's also a comfortable option for these patients and a visually pleasing option for these patients. So IKA, outside of our conference and outside of our bi-monthly webinar series that we've had, we want to put our message where our mouth is. And so what we did was we started writing papers. We started doing investigational clinical trials. Barry and a couple of his folks in Chicago initiated an prospective observational study in a population from, I believe it's 3 to 18 years old. Is that right, Barry? 5 to 18 years old.
That's right.
Looking at the pediatric 3 to 18 years old, and we have over 2,000 eyes, not patients, in the study, looking at the pediatric prevalence of the disease, because we know it's there. We know we have to get these patients diagnosed. And so our message is to all those, pediatric optometrists that are doing vision therapy and binocular vision work. Put a Pentacam, a shine fluid camera, or even a corneal topographer in your practice and look at those corneas. If you're a pediatric ophthalmologist working on strabismus surgery all the time and doing dilation irrigation on younger kids, put a topographer or a shine fluid camera in your practice and look at those corneas, because that's where the disease is starting and that's where we can make the biggest impact.
So, Alan, I'd like to kind of add to what Andy was saying. Very important. I think there are two key messages that we're going to get to our attendees, whether they're live or virtual. Number one is the importance of early diagnosis and management and treatment. But another one, to me, for all of the professions, is for us to stop working in silos. We are all guilty of this, and I've given lectures with that topic in terms of not working in silos with keratoconus before. You have some individuals in practice who will, if they see a keratoconic patient, they'll fit them in contact lenses till the cows come home, but they won't talk about progressive disease and management of that. You'll have others who go in and say, oh my goodness, if you're going to need a corneal transplant. They don't talk about vision correction. So there's a whole level of services that our keratoconic patients and their families, as Andy indicated, because we know that keratoconus is in fact a genetic disease that's influenced by environmental factors. So there's just a lot that needs to be considered in the comprehensive management of these patients, and that's part of our message during this meeting as well.
Excellent. Thank you for that. Now we're going to have last two questions before we wrap up. We're going to have a little fun. Here's a message from one of our viewers. They ask, and no Googling, spell Scheimflug. Go ahead, Andy. No looking. Don't look down. Look straight at the camera.
Look straight ahead. SCHEIMPFLUG.
Wow. So if you attend this meeting, you will leave knowing how to spell Scheinflug.
Absolutely.
And I'd like to nerd out for a second, and anyone can take this, and multiple people can take this. I think this will be really important. Tease some compelling new technology or recent research that our viewers will learn more about if they attend.
Well, I'll jump in from the vision correction standpoint. I think one of the areas that's the most exciting in managing these patients is addressing residual hiatal aberrations. Where our technologies now not only enable us to diagnose and measure residual hiatal aberrations, even with great keratoconic design contact lenses, but we now have technologies that can address them. And really, this is taking vision correction for these patients to the next level, well beyond improvement in visual acuity.
Can I ask Liz a question, actually, just from a surgery equipment perspective?
Hey,
like,
I'm the
because
interviewer
I don't know
here.
the
I
answer.
am the interviewer here.
Okay. Hi, I'm Alan Glazier.
Go ahead.
What's your favorite? I mean, other than cross-linking surgically, what's your favorite lens to use? Is it a single vision or a multifocal implant? If you're ever going to do a combined kind of keratoconus cataract type of surgery, is there a favorite device you like to use? Or
I'm gonna tell you, I think we are all like riding the same wavelength right now, because my answer to Alan's question and then to Alan Glazier number two's question is basically the same answer. So technology or topic that I'm super excited about answers exactly your question, which is we're talking about how to manage an early detection, but what I'm also really excited about is the technologies as it relates to the keratoconus patients who are coming in. And I'm taking care of these patients with this corneal pathology with cataract surgery, right? And what's so exciting is that for example, the IC8 Apthera off-label, it's a small aperture lens, and my numbers are low. I was in the original trial, so I had 17 eyes that were in the trial with normal corneas, but I've now done 8 eyes that have abnormal corneas, and it mitigates astigmatism. We understand what small aperture can do to extend up the focus and provide greater clarity of vision, mitigating irregular astigmatism and allowing for higher quality light rays to come through. Oh my gosh. So a patient truly with Ks of 52 was spectacle correctable. So that is one part of it, but really needed RGP to have his best vision, sclerals to have his best vision. So I aimed him. He did monovision, aimed him. He is 20/30 uncorrected for the distance, 20/20 intermediate, J2 near, happiest guy in the world.
awesome.
Unbelievable. So that kind of therapy in the non-dominant eye is the kind of technology that excites me. And that is one topic that I would like to mention that is also something that I think for the surgeon's perspective is also really a unique part of this, is how do we manage our older keratoconic patients who need cataract surgery, timing of cross-linking versus IOL technologies. We don't want to, from the monofocal perspective, I don't want to add or take away any aberrations. They already have so much negative spherical aberration and coma in their cornea. So I'm going to use a zero sphericity monofocal in their eye. But now we have next generation small aperture technologies that just got commercially approved. So that is another exciting area that we will have more expertise in by the time April comes. I do have firsthand experience with it, as do other members of the faculty by the time April will come. But this is the type of things that we will be able to discuss. And that is also very exciting.
Awesome.
Great.
Fantastic. Does that about cover it? Oh, we have another question from one of our viewers here. They're asking, Barry, will you please say residual higher order aberrations 10 times fast?
Residual higher aberrations. HOAs.
Sign up today where your discount code is residual higher order aberrations. But anyhow, so Liz, Barry, any last words?
Yeah. You guys need to come to the IKA first annual Keratoconus Symposium. Whether it's live, we'd love to see you in beautiful Scottsdale in April. It doesn't get better than that, by the way. That is the most beautiful time of the year. The desert is in bloom. All the cacti have flowers on them. And if you can't make it, it's a simple virtual attendance. It's going to be awesome.
That's great. Andy?
Yeah, I mean, what else can I say? I mean, we're trying to bring the message of keratoconus to everybody, and please come. This is it's a great event. We've got this guy Alan Glazier speaking there as well, so to bring them. I mean, I think it's really important to get that social media message out, Alan. I mean,
Yes.
there's nobody in the business that does it better than you do. So let's spread the word.
Thank you, Andy. All right, great. Well, listen, for our listeners, you'll see the link to register in the frame right here in front of you. And we'll have it on our YouTube channel as well as within the ODs on Facebook community repetitively working up to the conference. So don't miss this incredibly unique and highly informative COPE approved meeting. It's April 22nd and 23rd again in Scottsdale and online. And for the doctors here, I just want to thank you all so much for bringing this education to our industry and for being here with me today.
Thank you, Alan.
So much, Alan.
Thanks so much.
My pleasure.